Good afternoon, everyone. And this has been a great day so far. We're just going to move on to session 10, which focuses on communication and education. I'm Amrita John. I'm Assistant Professor of Medicine at Case Western Reserve University with training in critical care medicine and infectious disease. I'm currently on faculty at University Hospitals, Cleveland Medical Center.
And I'm Carolyn Sheridan. I'm a registered nurse, and I'm the founder and executive director of Ag Health and Safety Alliance. And we focus on agricultural health and safety to the agricultural population, which includes a lot about personal protective equipment. And Amrita and I will be moderating this session today.
This session focuses on standards around communicating and educating end users about the selection, use, care, and disposal of PPE. We will be looking at healthcare workers, other critical infrastructure users, and the general public, all of whom have their own considerations. The Product Standardization Task Force, or the National Strategy for a Resilient Public Health Supply Chain Task Force, number 23, Product Standardization, noted a need for technological advances to aid in PPE use and education, including developing training apps. Collaboration and coordination with employers is also important to protect the workers.
Equity issues really do play a critical role at this stage, ensuring that the underserved populations have affordable and accessible PPE to keep them safe. This is critical for workers who encounter a range of risks in their day-to-day and need to keep adequate protection. We have a very interesting panel representing a range of experiences, and we'll invite each speaker to share their remarks, and each will have 5 minutes to speak, and then we'll have a question and answer period.
If you'd like more information about the panelists, a link to the bios has been posted on the event webpage. If there's a question to ask the panel, please put it in the Q&A window behind the video player. I am now going to introduce our first speaker for today. This is Alexis Gill. She is the Director of Health Policy Programs at Farm Work Justice.
Thank you so much, and thank you for inviting me to be part of this panel today. My name is Alexis Gill. I am the Director of Health Policy and Programs at Farm Worker Justice. Farm Worker Justice is a national nonprofit organization based in Washington, D.C. that aims to empower farm workers and their families to improve their living and working conditions, immigration status, occupational safety and health, and access to health care. I very much appreciate that farm workers are being included in this conversation about PPE and PPT standardization and supply chain resiliency. As I'm sure you are aware, agriculture is among the most hazardous occupations in the United States. Farm workers are routinely exposed to pesticides, and with increased frequency in many parts of the U.S., especially in California and the Pacific Northwest, to wildfire smoke. While there are many reasons why farm workers lack adequate access to PPE, despite the many hazards they face, one of the primary reasons is their lack of workplace protections and their lack of control over their working conditions. It is important to remember that there are few regulations in agriculture. Pesticides, for example, are regulated through the EPA, not OSHA, limiting the scope of enforcement. There is also no national regulation to protect workers from heat or wildfire smoke, despite the increasing frequency of extreme heat and wildfire events. Therefore, workers are often reliant on their employer to provide PPE. Yet, we cannot assume that workers are being provided PPE, especially if there's no requirement for employers to do so. For example, during the height of the COVID-19 pandemic, many farm workers lacked adequate access to masks and other protective equipment to prevent COVID-19 transmission in the workplace, despite their increased risk of exposure. As a result, employers' provision of PPE and implementation of protective measures varied from farm to farm, especially in states that did not have any regulations in place. We also saw this during recent wildfire seasons, where we heard stories of workers who were not told of impending fires or increasing hazardous air quality and were not provided N95 masks for protection, And we all saw the photos of workers in the fields with only bandanas to protect themselves while the skies were lit up in orange due to the wildfire smoke. And unfortunately, this was not an uncommon sight. But even when workers have access to PPE, they may be reluctant to use it. PPE can exacerbate heat stress, which is a major issue faced by farm workers due to the more frequent and intense heat waves happening throughout the country. As I mentioned earlier, there is no national regulation on heat stress, so workers do not necessarily have the ability to take breaks during periods of extreme heat. Workers may also choose not to wear PPE because it can slow them down or make them more susceptible to heat-related illness. Farm workers do not have sick leave and are often working on a piece rate, meaning the amount they earn is based on their productivity. Other social determinants of health, including immigration status, lack of health insurance, and lack of transportation, among others, may deter workers from requesting or adopting PPE because it may negatively impact their work, which may lead to lost wages or perhaps employer retaliation of some sort. So we must consider these challenges when developing standards and strategies to promote PPE adoption among farm workers specifically. In the absence of regulations, employers must be incentivized to provide PPE along with proper training and accommodations. Sufficient supply of proper PPE to protect workers from hazards, including COVID, other infectious disease, wildfire smoke, and pesticides, must be available to employers at low cost and provided to workers for free. Workers should not have to pay for PPE to protect themselves from workplace hazards. Further, information and training about PPE must be provided by trusted communicators. Given the sometimes precarious relationship between workers and employers, it would be most effective to have communicators who are from the community, such as clinicians, healthcare providers, and community health workers. Community health workers especially can provide information to workers in formats and languages accessible to them. Examples include in-person trainings, low literacy materials like comic books or fotonovelas, and even the use of apps, including specifically WhatsApp, which is largely used by farm worker populations. It's also important to note that community health workers are often at community-based organizations, so there should be funding to support these efforts as well. So in conclusion, farm workers are essential members of our economy and community who deserve equitable access to safe and healthy workplaces. And I very much look forward to discussing strategies to support PPE and PPT adoption among farm workers and other vulnerable workers with the other panelists and all of you. Thank you.
Thank you very much, Alexis, for that presentation. Our next speaker for today is Elizabeth Royal. She's from the Service Employees International Union and is the Assistant Director for Healthcare Workforce Strategy and the Director of the National Nurse Alliance.
Hi, everyone. Thank you for having me today. Again, I'm Elizabeth Royal. I'm the Assistant Director of Healthcare Workforce Strategy in the Healthcare Division at the Service Employees International Union. We're a union of over 1 million healthcare workers across home and community-based settings, nursing homes, hospitals, clinics, and state and county public health. We also represent a little less than 1 million workers in the service industry, education, and non-healthcare public services. I want to talk a little bit about the experiences and needs of healthcare service workers today for today's panel, particularly focusing on their experiences during the pandemic. So again, I think we know that the rollout around protection and training for essential workers, especially in healthcare, during the initial stages of the pandemic were rough. We didn't know much for a relatively long time, and folks risked their lives to keep us safe, to heal us, to keep our country moving. They went to work every single day, not really knowing what they were walking into. They would come back to their houses, often stripping down in their cars or garages, showering in efforts not to sicken their family members. A lot of folks maybe even left their homes and stayed in other places so they wouldn't make their family members sick. It was a really, really traumatic time. And we know that essential healthcare workers were sickened by COVID and died at disproportionate numbers in the initial months and first year of the pandemic, especially in emergency departments and nursing homes. We lost thousands of healthcare workers. We learned a lot, unfortunately, from these horrible conditions. Early on, supplies of PPE were tight. We saw images of nursing home workers wearing bandanas as respiratory protection, hospital workers in trash bags instead of gowns. Folks ran out of small size N95s in emergency departments and were forced to use ill-fitting equipment, often becoming sick from that. Since then, supply has improved. For the most part, folks are getting access to PPE with fewer instances of hoarding by management, which is sometimes still a problem around good quality respiratory protection. We have a lot to think about and work on for the future. Just echoing what Alexis said earlier, we need robust, consistent education programs on why PPE is important, how to don and doff properly, proper fit testing and medical evaluations. These are often required for certain settings, but not for all. And there's not often an enforcement mechanism that's really reliable if they're not happening. We've had, this is especially true now, given the rate of turnover in healthcare settings. It's often really important to have a very rigorous schedule around fit testing, medical evaluations. And we've had issues with fit testing in nursing homes where they weren't being done correctly, the kits were defective. And again, this was blamed on turnover. And we know that's not an excuse. This is very important. Education and training from trusted sources. Often labor management training funds are also a good way of sort of making sure workers have what they need to protect themselves. We must have a wide variety of sizes and the best variety of PPE that's comfortable. We've seen pictures of folks with marks on their faces and skin breakdown from PPE, and it's really hard sometimes to make that decision to put it on when it hurts because your skin is raw. We need a wide variety of respiratory protection so folks can make good choices as to what works best for them, but still offers this good protection. We need equity in distribution and availability, and to think about the needs of a very diverse workforce. This is PPE for folks from all over the world, different sizes, different shapes, different needs. And it's not enough to say that the dropping of mask mandates are problems. Folks are dropping down surgical masks or nothing at all in a lot of places where they would be better protected with better equipment. And we must plan for the next surge in usage. We can't have what happened in the early days of the pandemic happen again. We need to learn from that. We absolutely need a broad infectious disease standard that covers all healthcare settings, preferably all workplaces, and as well as the forthcoming COVID permanent safety standard out of OSHA, which should also cover a wide variety of healthcare settings, because we know COVID does not stay in one area. It is not only in a hospital room or an emergency department. We have to have transparency and enforcement and accountability on behalf of employers. There has to be a real mechanism for accountability. Every healthcare work setting must have robust healthcare hazard plans and real penalties for noncompliance. And we also need to start thinking about infectious disease as existing in broader spaces. And what do I mean by this? There are an estimated 3.3 million home care workers who care for our most vulnerable Americans, providing essential care and supports. They're often paid through Medicaid, and they're considered to be employees of the consumer of services. They don't have access to any sort of standardized training, education, high quality PPE. They're, again, paid through Medicaid. They're low wage earners. And they are not in any way connected to the rest of the healthcare system in a formal way, but they are absolutely impacted by COVID, both themselves taking their consumers to medical appointments. Their consumer might have COVID, they might have COVID. No one is making sure that they have what they need to keep themselves and their consumers safe. Often their union would step up to make sure that they had PPE kits and educational sessions, but many workers without a union had nothing and no one to bridge that gap. So again, we can't just imagine that infectious disease can be contained in a room or a wing or a section of a building. We have to think about everyone in that setting and around that setting and who comes into contact with folks in those settings, and think about how they come into contact with airborne infectious disease and how we can protect them. And we can't rely on employers to just do the right thing. We need to help workers protect themselves on the job we need real enforcement mechanisms and penalties for noncompliance. Again, we need to make sure workers have all the information they need from trusted sources, and training and access to quality PPE they need to do their job safely. So the COVID pandemic, just in sort of closing, changed the conception of where infectious disease is for a lot of folks. And we do need to prioritize education and access and training around how and why and when to wear PPE, and ensure equity and access, and make sure everyone has the ability to make good decisions. And thank you very much. That was very jarring, but that was an excellent indication. So thanks so much, everyone.
Thank you both, Alexis and Elizabeth, for your comments. I look forward to hearing more from you and from the panel in response to your comments. Our next two speakers will discuss more about communication, and we've certainly heard a lot about communication over the last 2 days. So our first speaker is Andy Livingston, who is a director for OSHA's Directorate of Standards and Guidance. Welcome, Andy.
Great, thanks so much, and I'm very happy to be here. So as OSHA thinks about the communication issues, we communicate to both employers and workers. There's different focuses of our communication and different challenges, but one of our bedrock principles is that the employers have ultimate responsibility because they're the ones who are making choices on PPE, who are purchasing it, who are setting policies and procedures. So that really is ultimately our main focus, because that's where, from our regulatory and enforcement perspective, responsibility lies. Now, during the pandemic, there were some very real challenges around COVID. The science was evolving, and looking back now, we can forget that there was kind of this ongoing debate of contact versus droplet versus airborne transmission. At the beginning of the pandemic, everybody was wiping down groceries, right? And kind of the thinking has evolved. The other piece that was going on at the time was there was a scramble to figure out not just which route of transmission, but which route of transmission was of greatest concern in which setting. And the notion that in healthcare settings, that some routes of transmission might be more of a concern than in others. The other thing that, as we're talking about communication and this complicated things, is, again, with that notion of droplet transmission, that changes the way that you talk about PPE. And if you look at kind of the ASTM F2100 standard for medical masks versus the new F3502 barrier face coverings, there's a lot more variability in filtration and no attempt to address fit in the F2100s, because they're approaching it as a droplet transmissible disease. And all of these things really complicate the way that you try and explain to people why they're wearing certain PPE and how to use it effectively. Another particular challenge during the pandemic was there was a very strong desire for one United States government voice on COVID recommendations, right? One of the things recognized very early on was we couldn't have OSHA saying one thing and CDC saying something else and NIH saying a third thing and CMS saying a different thing and NIOSH saying another piece, right? There's so many different government agencies, and there was a very strong desire not to confuse the public with competing or conflicting recommendations, even though, again, some recommendations were for public health and other recommendations were for worker safety and health. Getting that alignment takes time and was a very challenging aspect. Another piece of this is there are some pretty fundamental differences in the way that the medical community and the epidemiological community looked at these issues than in the way that the industrial hygiene and the OSH community looked at those issues. And so there's kind of some very institutional, I think, biases in the way that people approach those problem solving, and that dramatically affected the communication and the recommendation efforts. The other thing, as we go back in the Wayback Machine, supply chain was a very real factor that affected recommendations and communication. There was a pretty strong debate about this concept of, should you give people the best recommendations for the best PPE based on health information and science, versus frustrating people with recommendations that weren't feasible for them to carry out because there was limited PPE, and or a panic might create a run on the PPE and exacerbate the situation. This tension between pure health-based information and considering feasibility plays out all the time. And if you look at NIOSH, when they do chemical recommendations for exposure limits, they're NIOSH RELs don't consider the feasibility of implementing the recommendations, whereas OSHA's permissible exposure limits often result in higher chemical exposure levels, but we're required by law to consider the feasibility of implementing them. So this tension in public health of what do you recommend and how do you recommend it and what goes into the recommendations is a very natural, normal, and regular tension as part of communication on what people should do. The other thing that I think was a significant concern for COVID was the supply chain issues and ongoing confusion with KN95s, with other countries' respirator standards, the eventual discovery that there were a lot of counterfeit and falsified products from the KN95 marketplace. As we later discovered, many of the KN95s were being delivered with ear loops instead of head straps later on. And so that created a whole other complication that as OSHA, NIOSH, FDA, and the other parts of the federal government were trying to calibrate what we were recommending, the landscape was shifting under us. And that, again, created some pretty significant challenges. Another challenge with communication is earlier on in the pandemic, OSHA took a compliance assistance approach, recognizing that people were just trying to come to grips with and deal with an evolving and emerging situation. We shifted over time to more of an enforcement approach, but this concept of voluntary guidance versus regulatory requirements during an emergency is not always a clear and simple communication effort, and it takes time to kind of adjust the we're here to help and we want you to do the right thing and protect workers, but we're not really primarily in an enforcement mode, and get that shift to, okay, now we're 6 months or a year into the pandemic and the supply chain has changed, and now we're ramping up enforcement. Another particular challenge around communication was early in the pandemic, people were doing the spit and baling wire and duct tape versions of masking, right? It was everybody had, and their mother had some recommendation on how to make a mask at home using a pillowcase or a t-shirt or other material. From OSHA's perspective, when this PPE was homemade, it was not really considered PPE by OSHA under our 132 PPE standard, because it was not designed or manufactured to a standard. And you saw that there was really tremendous variability in the type of protection provided by that PPE. Again, going back to that kind of ASTM F2100 medical mask versus the F3502 barrier face covering. Again, there's complications in how you describe the level of protection and what people should do with various types of PPE. If you review the literature, there is tremendous variability even within medical masks that meet the FDA's 510K process and ASTM. You can find things with 20% filtration, and you can find things with close to 90% filtration. It really is tremendously variable, and that creates some pretty significant complications. One of the questions that the committee asked is this notion of, should workers be allowed to protect themselves? And one of the challenges, particularly in our respiratory protection standard, is that 1910-134 does allow employers to prohibit voluntary use of respirators, because the respirators can become a hazard in and of themselves. Now, when we did our emergency temporary standard, we actually shifted the balance of power on that to allow workers, because of that recognition that there's some individual risk factors beyond occupational risk factors that may cause a worker to want to wear PPE, even though their work or their employer may not require folks. With respect to COVID, there's some ongoing challenges. For example, we still don't have good guidance on extended use and reuse. And there's not a lot of good science on this notion of how clean is clean. If I wear it continuously for 8 hours, is it okay? What if I put it on and take it off? That goes for both respirators and face masks, and was an issue before COVID, but we've never seen it become an issue like we did during COVID, where the supply chain really exacerbated this issue of extended use and reuse. So coming out of COVID, we're doing a lot of things to increase our communication efforts. We saw videos become a lot more popular as a mass communication tool. So we're developing a lot more videos on more detailed aspects of respiratory protection programs. We're focusing in particular on the importance of fit and leakage, getting that tight seal as a really crucial factor for airborne transmission. We're doing work particularly on facial hair and how it affects fit. We're doing more detailed work on how to teach people how to conduct fit testing. We saw a shortage of people being able to conduct fit tests as a major barrier to good respirator use, particularly as you saw respirators extend out into nursing homes and other kind of extended care settings where they didn't typically use respiratory protection. And then we focused a lot also on selection, particularly N95s versus P100s. Those are really kind of the two archetypal filtering face piece respirator types, and helping people understand when and how you would make different selections. So I want to just now, and I know I'm over time, I want to ad lib on one thing that I heard at the closing of the last session, which is this notion of better PPE, in particular for healthcare workers. It's possible to make better respirators. For example, many P100s that people would call welding respirators are disposable, but they have double sealing surfaces, they have adjustable head straps. Those things push it from a 50-cent device to a $5 device. And one of the problems is that the healthcare community has always wanted the cheapest and most disposable devices possible for other infection control purposes. And so that's driven people to produce the bare minimum. And as long as the standards allow the bare minimum, the people in the healthcare community who are in charge of purchasing are going to keep selecting the cheapest devices available. So if there really is a desire to elevate the baseline or the foundation PPE that's provided to healthcare workers, I think it's going to require a change in the standards to prohibit some of these cheaper devices from being used in those settings. And with that, thank you for the time.
Thank you very much, Andy. I think you did a good job of articulating what a lot of us were feeling and still experiencing. I'd like to invite Sarah Cofield to speak now. She's an air quality specialist with the Missoula County City and County Health Department. Welcome, Sarah.
Thank you so much for having me. So I'm here to talk about the public and advocate for the public. As an air quality specialist, my focus is largely going to be on wildfire smoke and wildfire smoke exposure. And the fact that people want to protect themselves from smoke, obviously the best way to stay protected from smoke is to not be in it at all, be able to leave the area or stay indoors in a place with cleaner air. But for a lot of people, including outdoor workers and including just the general public spending their time outside, that they're going to need something to protect themselves. And the best option for that really is that filtering respirator. But you know what? They are not made for the general public. And that is an issue that we run into. They are designed for workers and they are not comfortable. They are hot. They can cause heat stress, which if you're a person in the general public, you're supposed to put something on your face that kind of hurts it and can make you feel less well because you're all getting hot and uncomfortable. You aren't going to use it properly. And there's also the fact that the instruction and the guidance around how to use respirators are targeted toward workers. Aren't in this idea there's going to be fit testing and medical clearance. The general public is not going to get fit tested. And how often do you actually go see your primary physician? You're not going to go see your primary physician if smoke rolls into town. You need to know if you can use a respirator. That's not going to happen. So we need products, as has been mentioned multiple times, that don't require all these added layers to their proper use. They need to be super intuitive. Because you know what, people don't read. And I'm not saying this as like there's a low literacy issue, although we do have a low literacy as an issue. We have low scientific literacy as an issue in this country. But when someone purchases a product, they expect to be able to just use it. They expect to be able to look at the design and figure out how to use it. I myself am guilty of this. I bought a new water fountain for my cats and I just set it up and had it go. And there were a lot of parts. And I just figured out I can figure this out by myself intuitively. I did a pretty good job. Then I went and looked at the pictures. And so we need to be aware that how the public takes in guidance is they don't like really technical language, and it needs to be as simple as possible. There was a conversation about harmonization of what is said about different uses of PPE and what should be used. That is an issue for the public as well. It's not just what workers need to be doing. We have found that in a given wildfire smoke event, you may be getting conflicting advice on if you should use a respirator, should you not use a respirator, depending on who is speaking. So that kind of recommendation needs to be harmonized across all levels of government and people putting that message out into a community. Another difficulty with the discussion about PPE with the public that goes back to the PPE being designed for workers is there is not PPE that's appropriate for everyone in the public. You know, I gave a talk about wildfire smoke on Tuesday to a community group. I was like, hey, if you have to be outside, consider a respirator. They do not come in children's sizes, you know, and so if you have a child, yeah, you can consider a KN95 if it's like a legit one, if you can get that seal, but the odds of getting a seal, not super great, and they're not going to get a fit test for that child. So we have these issues of the products aren't even designed for use by the general public, and that makes the guidance even more difficult to be like, well, here, consider this, but oh, you can't, and oh, you can't protect all of your family, and oh, you have someone who's frail and or disabled, and that's might not be appropriate for them because they might have difficulty putting something on or putting something off their face. And then you have PPE beyond just respirators that also can cause discomfort and heat stress. And if something is uncomfortable, you're not going to want to use it. One of the other difficulties with communication and guidance is that risk communication and convincing people that they need to do something. We run into this with wildfire smoke where people are just kind of used to it and they think that, yeah, whatever, it's kind of gonna suck, then it's gonna get better. And so they might not have that sense of, oh, this is really dangerous for me, it's dangerous for my family. And so I should take steps. So you have to figure out, okay, how do you get that best risk communication to then see the public actually use the PPE and then get the information of how to use it, the PPE correctly. And then there's also added to that, the difficulty of socio-cultural and behavioral issues that underlie when and if someone's going to use something. We saw this a lot during COVID. If it was not socially acceptable in the area that you were in to put something on your face, you weren't very likely to do it. And so we need to figure out how do we best communicate when we have to take all of these considerations into our calculations of how do we design guidance that is meaningful and can get to people where they are and help them take up these technologies and use them appropriately. Because even if people know about respirators, even if they know they should wear them, might not be able to use them correctly. You know, there were studies after Hurricane Katrina where people had heard use a respirator when you clean up mold, but they weren't able to don or doff them correctly because they had not received that specific training. They just were told, hey, go out and do this. So there's a lot of work that needs to be done if we want to protect the public from hazards, respiratory hazards from infectious disease or air toxicants like wildfire smoke. And then, you know, obviously there are also sources, things people need PPE for if they're dealing with chemicals and whatnot in their daily lives. But we can't just be so narrowly focused on the worker in our communication and assuming that there's going to be training for the use of that PPE. There has to be just super easy to understand usage guidance with preferably as few words as possible to help people get to where they can just purchase something and use it correctly off the bat without needing to go and seek help outside of their own kind of common sense, which I apologize if that sounds a little bit trying to oversimplify things, but trying to meet the public where they are and help them be successful and protect themselves and their family's health as they go out into a world that has hazards that people should be safe from and not be told to go and figure out on your own.
Thank you very much, Sarah and Andy. Also, Alexis and Elizabeth for your comments. Now we're going to open it up as a panel and ask for some discussion about the things that we've heard. Also, we encourage the individuals or the individuals that are watching this, the live streaming, to also provide us with any questions or comments that you may have. I would just like that an observation. It felt like that we're all been living through this, and having lived through it as a registered nurse and then watching our communities. I think that unfortunately, the lack of good communication caused divides not only in communities and not only in healthcare facilities, but also within families. And so I think that as we think about how is good communication and good information, which does relate back to standards, also relates back to how is the communication coming from the different organizations. As a healthcare provider, I certainly respect and understand NIOSH and OSHA, and I very highly evaluate the information that's been coming out from there. Other individuals and communities don't even know what those words mean. They don't know what NIOSH is. They don't know what those things is. So how do we, and I would like to ask Alexa, you as from Framework for Justice, I know the work that you've done, and you've done some very creative work in communication and how you communicate with underserved population. Maybe you could talk just a little bit about that, your communication strategy.
Absolutely. So we are a national organization. So we work with community-based organizations across the country, and we employ a training of trainers model. So we train community health workers, promotores de salud, primarily from community-based organizations or organizations that work directly with farm workers. The community health workers are either former farm workers, or they are family members of farm workers, but they are in the community, and we train them in these various issues, including pesticide safety. We've done dairy worker safety, COVID-19, of course, and how to protect themselves with COVID-19. And that information is provided in various languages, Spanish, as well as the creation of materials in low literacy accessible formats. And that includes not only Spanish, but also indigenous languages, because many farm workers are coming from indigenous communities, maybe limited Spanish proficient. So understanding the diversity of the population. But also using those trusted communicators, as others have stated, having those individuals in the community who are from the community, part of the community, providing that information is really meaningful. But I do want to reiterate the fact that even with all the education that we provide, if employers are not providing environments to allow for workers to protect themselves and encouraging the use of PPE, providing PPE, making accommodations, and providing proper training to their workers, workers will likely not take up adoption of PPE. So, the workers only have so much agency, and they want to protect themselves. They want to protect their family members, but they lack agency, unfortunately, in their work environment. And so we have to think about it not only as education specifically to workers, which is extremely important, and creating education information that's accessible for workers. But also we need to think about the broader regulatory environment and the fact that, farm workers oftentimes are not able to assert their rights or are able to ask for the protective equipment that they require to be safe in their workplace.
Thank you very much. Yes.
There was another question I was thinking about, and I'd like our panelists to comment on. How can healthcare workers help educate and communicate with workers about using PPE and protecting themselves? What skills do they need to be able to support and treat and educate people on PPE use?
sorry. So I'll take a stab at this. I mean, I think for a lot of folks, again, as Alexis was saying, we need a lot of like cultural competencies and a wide range of language abilities. I think a lot of folks, especially nurses, are considered to be, you know, the most trusted voice in healthcare. 15 years running, using, you know, the healthcare worker voice to talk to other you know, talk to the general public. You know, we've got public health nurses, folks who are, you know, are able to talk about the importance of anything from vaccine to masking, which I know are all hot button issues. But, you know, it has to come from a trusted source. It has to come from someone who's not seen as having an underlying motive for doing things. Like sort of a different sort of example is like during the vaccine rollout, we were often advocating for folks, docs and nurses from the communities in which they worked to talk to, like, say, nursing home workers or home care workers about the importance of vaccines or masks. And it was, they were both able to say, listen, I'm from your community, I understand. And also they were just trusted resources and people felt comfortable asking questions. So, I mean, you really can't overstate the importance of a trusted voice in these moments.
I would just like to say really quick that one of the challenges with that is currently a lot of the medical community is not trained up on PPE use and also even what the medical counterindicators for use might be. And in public health, we dodge the question of who should and should not use PPE by saying, ask your doctor or ask your medical professional. And that is putting people on the spot who haven't actually probably received a lot of training on that. They also don't receive a lot of training on air pollution as a hazard and as a health thing that they need to be talking to their patients about. So there are gaps even in medical training to get us to a point where we can turn to medical professionals and say, can you help us reach out to our public and to our workers to help them better protect themselves. So we need to make sure that that training takes place for our medical professionals so that when they're put on the spot, they're ready for it and have the resources that they need. Because right now, even just asking someone, hey, is this person okay to use a respirator, unless they are like actively involved in our PPs and do that as part of their daily job, they might not have a great idea of what to be looking for and to give the best response necessary. So I would advocate for better training for medical professionals in the use of PPE for the public and for workers.
I think too, there was mention of respirator fit testing and sometimes the difficulty in being able to get fit testing. So certainly appreciate all the advances that are happening. And Andy, you mentioned about some of the new information that is coming out about facial hair, things that definitely relates to having the right fit. And so maybe the question for you, Andy, when you're putting together the educational pieces or the information, how are you determining, is this public or is this healthcare? Maybe just talk a minute about that.
Yeah, so we're approaching it in a much more generic way. It's for all workers, but it's also the sort of information that the public could certainly use. We have done in the past specific videos targeted at just healthcare workers, but this is one where it really is a universal issue. And I think the challenge is that people don't understand the importance of fit. People will focus on, is it an N95 or is it a P100? And they look at the filtration, and what they don't recognize is that that N95 filter is getting, you know, in many cases close to 99% efficiency at filtering things out, but you're getting 10% leakage, even in the best case scenario of a proper fitting respirator, right? So it's the fit that really matters in many cases, much more than the filtration. And when you see people, you know, wearing respirators and or face masks below their nose, you see people, you know, pulling them off to the side all the time to, you know, to talk or to eat or drink, or just to take a break, right? It really shows that people don't understand what the true mechanism of protection is. So, you know, that's why we're doing all of those videos, but they'll work for everybody. But it is a very big challenge in terms of fit.
Any suggestions from our panelists about how our end users could improve their own agencies to advocate for themselves? We've talked about how farm workers often don't have rights, but we saw this during the pandemic where physicians and nurses got fired because they used PPE equipment and the hospital administrators didn't feel it was necessary. So how can we provide our end user with more agency?
Yeah, well, on behalf of OSHA, we do an awful lot of whistleblower investigations where people raise these issues, and we offer protections to those workers. And in the event that their employer does take some sort of adverse action, we can get them, recovery for, lost pay or other sorts of harms. So we saw certainly a surge during the pandemic in people filing complaints, whistleblower complaints around that issue. But it is a complicated issue because the employer does control the workplace, and under many state and local labor and employment laws, that employer does have rights. Particularly, and again, under our normal respiratory protection standard, the employer does have the right to deny voluntary use of respiratory protection. Again, that was something that we shifted in the pandemic for the first emergency temporary standard, but this notion that a respirator is a serious piece of equipment with potential adverse health consequences if it's not used appropriately is a real concern and is a codified part of our regulation, and is something that would require us to change it if we wanted, under a more permanent basis, to allow people to have, to allow workers to have those rights. The other thing that I think becomes a very significant challenge is when workers are dealing with an established hazard, a recognized hazard, right? That's one very specific scenario where we can make sure that those folks have more protection. When you're in a gray area where it's recommended or considerate, not necessarily even for workplace issues, but for your own personal health risk factors, or even family members, right, that you live with who may be medically compromised, that becomes a much, much more challenging legal situation to deal with in terms of who has rights to do what when. And it's not something that, that is even necessarily within OSHA's authority and jurisdiction. That's probably a larger legal issue potentially for Congress.
Well,
So potentially personal rights and liberties issue is what I'm hearing.
Well, and one thing I really love to throw out there that was just kind of alluded to was recognized hazards where respirators are required in the workplace. We know wildfire smoke is really, really bad for you. We have the studies that show that during a smoke event, people get sick and they die, or they have lost work days, and there's an economic loss due to wildfire smoke. But it is not currently a recognized hazard in most of the country. The only states that have done anything to address wildfire smoke exposure for outdoor workers are Washington, Oregon, and California. So all the other states where you have smoke and you have outdoor workers, there's nothing that says they should have any protection at all. Now, granted, even enforcement of those rules that exist in those states is a little shaky, but at least they're a start that says that workers should be able to have respirators and be provided respirators when you hit the AQI at a certain level. But you get out of those states and there's not the protection at all. So that is a place where standards can come into play on a national level and actually recognize these hazards as something that is deserving of action to protect all workers that are being exposed.
Thank you, Andy and Sarah, for coming back to think about general exposures, and not just respiratory, but thinking of all the other types of PPE that we've talked about that need standardization, need communication, all types of PPE as well. And there's been so much happening with COVID, and we've talked a lot about that. And as we continue to move through what's happening with the pandemic, we also need to keep considering all the types of things that we need protection from normally. And how do we have good communication, and how do we do good role modeling as healthcare providers? I think that we certainly, this panel itself has a lot of good experience and ideas about that as we think about general protection.
And if I can just add, in terms of wildfire smoke, so, California, Oregon, Washington have regulations in place, but the regulations are quite complex. And it's not necessarily standardized throughout the 3 states. So each state has its own regulation pertaining to wildfire smoke. And what I've heard from colleagues in Washington state, and they are in the process of finalizing a regulation, a permanent standard, is that there's not a lot of information out to workers about the regulations themselves. And so, when these regulations are in place, it's important that there are ways and efforts to educate workers about their rights and to have them understand this is what the standard says, this is what is required by your employer, but because it's so complex, again, doing it in a way that is accessible to a wide variety of workers who are impacted by the regulation, but ensuring that that education gets out there, and that workers are aware that these rights are there and that there are mechanisms in place if the employer does not provide the protective equipment that is required under certain AQI, that there are ways that they can have those standards enforced. And that's connecting them to legal services, which is also very important.
We have an audience question here regarding agricultural workers and training materials. Can the panel discuss the ISRP education work for developing countries or other similar train the trainer models?
I am not familiar with ISRP. But train the trainer models are extremely effective. OSHA, through its Susan Harwood training grant, really emphasizes the training of trainer models, funding organizations to provide trainings directly to workers, on various health and safety topics. And the reason why it's extremely effective is because the workers are able to use a popular education format in order to provide that information to workers, and are able to do it in a variety of formats and in a variety of locations. So it's not as though it has to be done at the workplace. It can be done at church. It can be done in the housing. And wherever workers are, you meet them where they are. And so those types of training of trainer models, and then accompanied by resources that are in accessible languages and formats, has proven to be actually extremely effective.
So just to clarify, it's ISRP's International Society for Respiratory Protection.
Oh, thank you.
Thank you. Thank you. I was like, I should Google that real quickly.
So has there been consideration, like you mentioned, churches and other, like taking this training and this conveying this education outside of medical and healthcare models, say the DMV, you go to renew your license, and it sounds like this problem is not now restricted to healthcare. You have wildfires, general public is being exposed to it, chemical exposures like we saw in East Palestine in Ohio. And so then you're waiting in the line to renew your license, and then, oh, okay, someone teaches you how to use a respirator. Is there models looking at training outside of medicine or healthcare?
I think our organization is working hard on the next generation of agriculture. We're teaching those college students, and they certainly have a lot of concerns and questions. And throughout the pandemic, we remained at the colleges. Very rarely were we virtual, and it was interesting to see their fear. It was interesting to see that they had lots of questions and concerns, and not just those in agriculture. So I really like that idea that you just talked about, like what other places and where else can we get good education from other types of people that are trusted, not just healthcare providers. So I think that's a very interesting concept, and I'd be interested to hear what others on the panel think of broadening that group who can certainly become trusted and help with communication.
Well, that's really important with any big public outreach effort or attempt to get out there. Like I mentioned earlier, and I apologize for my comments were all over the place, but we do need harmonization of guidance coming from the big agencies. But then that needs to be disseminated at the local level. It needs to be meeting people where they are with people in their communities who they can talk to. So those folks at the local level need good resources to use and need appropriate and culturally appropriate resources to use. You know, I was giving a talk on a reservation on Tuesday, and the stock imagery for how to use reservoir protection correctly and improperly had a white woman using it correctly and a dark-skinned man using it incorrectly. I'm like, oh, that is not, I'm not doing that. I'm not taking that with me. Because it's like, oh, that felt really, really gross. I didn't like it. So having something that is really culturally neutral would be nice to put into guidance and take into different communities, or make it really culturally appropriate for specific communities and really tailored for where we are. But yeah, getting it, we need central messaging, and it needs to be dispersed really hyper locally by those trusted folks in individual communities. And then the challenge is finding those champions and giving them the tools that they need to get out there. And that's a task. That's definitely a task, but public health happens really at the local level.
Yeah, I mean, we've worked in instances with non-traditional stakeholders. For example, there are church groups that are doing advocacy for certain, Latino worker communities that, have immigration status issues or other things, and they're trying to just, keep them safe. What I would say is the question that you've asked works well in principle generically, and in practice, I think is very tailored to whatever the hazard is, where you would find people that might naturally talk about that hazard, and who the trusted sources are in those communities. And so I think it's, a good recommendation generically that we should find third-party surrogates to amplify the message. But I think it's really, the way that you talk about a COVID response or a public health response would be different than maybe, a train derailment or an oil spill leak or, other sorts of things. And you have to figure out what works in that constellation of communities and hazards.
Thank you. Okay.
I think we are, looks like we're going to get gonged. What do we call that noise? Is that like gong noise? Go ahead, Emery.
No, I think we have just one last question here. Someone asked about what role could pharmacies play in improving access to fit testing and also education?
So I guess I'll jump in on that one, and I don't really see that being a viable thing to offer through pharmacies. Fit testing is the sort of thing that takes training and practice and often equipment. We saw the American Industrial Hygiene Association and the American Society of Safety Professionals help people find local community providers who are trained safety professionals. But doing fit testing takes time and money, and it's probably more time and money than it pays to have a pharmacist be the person delivering that, given the cost of that person's time and the other sorts of issues that they deal with. So I have a hard time seeing that model being economically viable, but there's certainly no reason you couldn't teach people how to do it. It's just, I think in some ways, a better thing would be more likely partnerships with local fire departments, where you could get a local industrial hygiene provider to come in and do fit testing there, because there you already got people who are very used to wearing respirators and are seen, right, wearing a self-contained breathing apparatus and all sorts of PPE. I think that's probably an easier fit.
And I'll just make a cut. We did, I've had a number of pharmacy techs and pharmacists who have asked and who have been interested in understanding fit testing. And I don't know that the model's been tested, as you've said, Andy. I think it's interesting to think about models such as that. And I was very encouraged when they asked for more information, so that I will see where that leads. I think definitely right now we'll need to thank our panel for their remarks, and thanks to the public who did have questions for us. We'll now take about a 30-minute break, and we return at 1:50 p.m. Eastern time. I know we have a lot of people in the audience and also on our panel who are from different time zones, so keeping in mind it's the Eastern time zone. When we return, we'll have 2 sessions and look forward to how to prioritize our response to the gaps that we've discussed today and yesterday, and what ideal standard process is supportive of resilient supply chain and what that would look like. We look forward to seeing you after the break. And Amrita, any last comments from you?
No, this has been amazing. Love the discussion. And Andy, along the lines of what you said, Marianne wanted to mention that they are doing a train the trainer effort with public health departments and fire departments. They're going to pilot this in California and then hopefully roll it across the nation. So thank you. Hope to see you all at the next session.
Thank you very much.